Awesome. Thank you, guys. I'm Matt. I'm one of the ICU attendings here in Little Rock, Arkansas, USA, at Arkansas Children's Hospital, and I help out with the ECMO program as well. Thank you, everybody, for being here. And a super huge thanks to our panelists, Dr. Bob Digeronimo, Dr. Matt Friedman, and Dr. Aparna Hoskote for being with us today. And a special thanks to Dr. Hoskote for joining us at odd hours across the pond. So we'll go ahead and get started. Sorry, I guess really quickly, I should say who everyone is. Dr. Matt Friedman is at Riley Children's Hospital, Indianapolis, USA. He is the medical director of ECMO there and publishes on ventilatory strategies for pediatric ICU management on ECMO. Dr. Hoskote is over at Great Ormond Street in England. She works in the CVICU there and is our CVICU ECMO expert here and is a wonderful speaker at multiple ELSO meetings. And then Dr. Bob Digeronimo is a neonatologist in Seattle who runs their neonatal ECMO program and is an amazing speaker as well. And we welcome all of them for their expertise here with our interdisciplinary panel. So we're going to start with a case just to kind of level set everybody to what we're thinking about. And then we're going to break off in some questions here. So our patient is a 25-day-old baby who's 4 kilograms, who presented with fever, poor feeding, difficulty breathing. He was intubated due to respiratory failure. He has bilateral parenchymal disease, and his cultures from the outside hospital are positive from gram-positive cocci in clusters. On the ventilator, he's in pressure control mode with the settings seen here, PIP at 30, rate of 28, and PIP at 8, requiring 100% FiO2, and his saturations are in the low 80s. Despite his peak being escalated to 16, his oxygen saturations and status did not improve, and so he was placed on VV ECMO. And the cannulation proceeds without complications. So that's our patient. We're going to work through. We'll have some updates to our patient as the discussion goes on. But our first topic for discussion is for the panel, and we'll start with Dr. Hoskote. What is your practice for mechanical ventilator settings after cannulation for respiratory ECMO?
My main ventilation strategy here will be dependent on what the indication was, the status of the lung and the clinical course. Now, initially, I would expect this child to be having a chest X-ray, which has, as you have rightly said, bilateral parenchymal disease. And for me here, our institutional policy, and I believe in that as well, is to go on to what we call as rest settings. Now, rest settings is something which is very institutional dependent. And the way I would look at it is just to reduce positive pressure ventilation and to, however, keep the lung as inflated as possible, in the sense like to have the peak optimum, reduce the FiO2. And we have a policy of bringing the rate down to about 10 per minute, 20 on 10, and a FiO2 of 0.21. This is what I would do in this case for this child.
Thank you. Dr. Friedman?
Thank you for having me. Yeah, a lot of what was already stated, I would agree with. I think our institution often sticks with the easy to remember 10, 10, and 10 of a pressure control of 10, PEEP of 10, and rate of 10, which I think is a great starting place for thinking from and seeing where your patient's at based on your chest X-ray, based on their compliance, and based on I also will adjust my vent settings based on how long I think my duration of ECMO is going to be, which immediately after cannulation you may not have a great idea, but you want to keep that in mind when you're setting your vent settings, when even from the beginning, how long you expect to be on ECMO. But the general principles that Dr. Hoskote pointed out of limiting lung damage by limiting PIP and FiO2 and by judicious use of PEEP to encourage recruitment as possible is the general principles that I'd adhere to.
Thank you, sir. Dr. Digeronimo?
Yeah, also thanks for having me as well. Yeah, in our center, especially for this age of patient, we pretty much follow the published ELSO guidelines that are out there for neonatal respiratory failure. And our protocol pretty much is go to PIP of 20, PEEP of 10, rate of 10, and 21% oxygen. I would say we would vary that a little bit depending, again, on the underlying diagnosis. We probably would adjust maybe the PEEP a little bit if there was an air leak, but pretty much for most patients, those are the rest settings we go to with conventional ventilation. Yeah.
And do your centers have a protocol for this, or can it depend on provider preference or utilization?
Yeah, I know at least in Seattle, we have a pretty set protocol and pretty much everybody follows it. So we try to reduce variation, which works pretty well.
The guideline or protocol exists. I think is loosely followed for us, but there's a lot of individual variation, and that variation tends to increase as the duration of the ECMO run increases.
I think we have an institutional protocol, and going on to ECMO, I think we try to be, uniform in it and trying to minimize, and minimize post-pressure ventilation and going on to the settings. Yes, if there is air leak, then that would modify our rest settings.
Great, thank you. And I should have said at the top of the hour, as Dr. McKell is already doing, please feel free if you're in the audience to put some questions in the chat. Dr. Zivic will be monitoring the chat and will she will alert us to those questions as time goes by. Some of the questions may be things we plan on talking about already, so don't feel like we're ignoring you if Dr. Zivic doesn't speak up immediately. Thank you for that. So next slide. All right, so Dr. Digeronimo, you were part of a survey study published in 2022 evaluating respiratory management practices in neonatal ECMO from NICUs throughout the CHNC, the Children's Hospital Neonatal Consortium. What did that study find regarding ventilator strategies utilized amongst the centers?
Yeah, so I see there actually are a number of people that were involved in that study on the call, so hi to you. Basically, for folks that don't know, the Children's Hospital Neonatal Consortium now is about 45 centers and of NICUs, mostly in the US, a few in Canada, that are all level 4 centers, and the majority of which do ECMO. So we surveyed we have an ECMO focus group there, and we surveyed that group to see how folks manage ECMO. And basically, kind of the takeaways from the study were that about 65% of centers do use protocol-based guidelines. So I think, again, to the earlier question, trying to have consistency seemed to be important. The primary mode of ventilation at most sites is conventional ventilation, and the primary ventilator strategy is to use pressure control with SIMV. There were other centers that use volume control or pressure regulated volume, or a few that used some other settings. But the majority, again, used SIMV, pressure control, and again, tended to follow the ELSO recommendations using PIPs of 16 to 20, PEEP 9 to 10. Almost all centers try to target a PEEP of 7 or higher, again, with this goal of maintaining some lung inflation to try to prevent atelectasis. There were a few sites that use high frequency initially, but the majority use conventional. But the majority of sites would go to high frequency at some point if they wanted to adjust their rest settings if needed for ongoing air leak or lung recruitment or other concerns. Yeah, I think that's probably the highlights of the paper.
Great, thank you so much. Dr. Friedman, you published a similar study in pediatric veno-venous ECMO patients. What were some interesting findings from your study?
Yeah, so I was fortunate enough to lead a group of 10 centers. You can see the names of the group here, and some of these people are probably even on this call. So we had 10 large pediatric centers in the US, we looked at mechanical ventilation strategies on ECMO in a retrospective manner, and we were able to collect 204 patients and look at their outcomes. And the biggest findings were that ventilator FiO2 was the most strongly associated with mortality in this group. No pressure settings on the ventilator nor mode of ventilator were associated with mortality, which we were somewhat surprised that previous adult studies had shown that driving pressure, peak pressure has been higher driving pressure, peak pressure was associated with worse outcomes in adults. And I think the main reason we didn't see any differences in mortality with our pressure settings on the ventilator is most of these were experienced centers that were using similar strategies of low PIPs and moderately high PEEPs, where for example, our PEEP of the 25th percentile, 75th percentile, and median were all 10. So that meant more than 50% of our patients were on a PEEP of 10. So this, I think limited our ability to make some conclusions because there was such consistency in limiting PIPs and using moderate PEEPs. However, FiO2 was fairly variable amongst the centers and amongst the patients. And in univariate analysis, as well as multivariate analysis, adjusting for severity of disease, we found that ventilator FiO2 was associated with increased risk of mortality of 38% odds difference for every 0.1 FiO2 or 10% change in oxygen. So this seemed to be an important difference to us. So that was really the biggest finding, is really driven my practice to lower FiO2 on the ventilator as aggressively as possible.
Great, thank you. Dr. Zivik?
Yeah, I just wanted to touch on a couple of the questions in the chat that I think you guys may have sort of briefly spoken to, but people were asking, do any of you guys use volume ventilation settings for your rest settings or high frequency? And so it sounded like in some of the registry studies that you had just talked about that people are doing that in small numbers, but people are wondering if you all have any experience using those modes of ventilation.
Yeah, I could answer first. Yeah, we use all, we're familiar with all those settings. We used to use volume, for our rest settings, and there were, I think about 20% of sites used volume in the CHNC survey. So, targeting a normal tidal volume 4 to 5 mLs per kilo, at least for a neonate, probably lower in a CDH patient. And again, I think I mentioned, a small percent use high frequency primarily, and there were some suggested settings of mainly kind of with the same idea of what you're trying to do with conventional, where you keep a mean airway pressure somewhere of 8 to 10. You try to minimize your PIP shake pressure and lower the oxygen, and you can do that whether you're using the oscillator or jet ventilation or another device. But I think the principles are the same, but most people, I think at least in our experience, are using it more as a rescue.
To speak to volume targeted modes of ventilation, either volume control or PRVC, I don't think they have a lot of role for early in ECMO, as the main goal is to keep your PIP low, and you're going to have a lot of, it's going to be a lot harder to target your PIP keeping low when you have a dialed in tidal volume, and your lung compliance is likely to be changing and mostly worsening after going on to ECMO typically. So we don't use it. Additionally, oftentimes our tidal volumes are so low on ECMO that we have to turn off our tubing compliance calculation. So the tidal volumes that we're obtaining on the ventilator are not even real tidal volumes. But to keep the vent from alarming constantly, we have to turn off the tubing compliance. So we use pressure control pretty much exclusively early on in ECMO, but may switch to a PRVC mode later when we're closing in on decannulation.
Yeah, I would agree with what Matthew has just said just now. I think I would prefer pressure control, definitely over volume control. And again, the compliance is more than likely to be getting worse, and you don't want to generate very high pressures. So definitely pressure. The other thing, what I find sometimes it's really useful is that when you have on pressure control setting, and then you have those very low volumes when you initially go on ECMO, and then as the lung gets better, you see more volume being generated. And I think that sort of is an indicator, an early indicator to me that the lung might be getting better. And hence, again, I prefer pressure control ventilation. Of course, if there is, if there is any situation like air leak, then again, you have to be very careful with the pressure that you give, and you might have to limit to only PEEP just for the initial periods till the air leak gets settled.
Great, thank you so much. Elise, you want to move on, or you want to do another question in the chat?
Well, I think we've briefly talked about what they consider rest settings. One of the questions that did pop up was about the role of APRV.
I've used APRV in the past as a re-recruitment strategy for patients that have been on ECMO for a prolonged period of time and don't seem to be re-recruiting with a conventional mode of ventilation, with the idea that this might be a more gentle way to re-recruit injured lungs. There's no data to really support this practice, but that's my personal experience.
Yeah, there were a few centers that use APRV in the CHNC, but I would say the majority of neonatologists tend not to use that as a primary mode, and as Matt was saying, maybe more as a recruitment strategy later on if you're having difficulty.
Absolutely similar experience. Later on, it may be used when you have a situation where you're not seeing recruitment and you're using every strategy, and APRV may help. But the other thing I just wanted to mention is that high frequency, I'm not a big fan of high frequency on ECMO, unless it's in the very late stages, again, when you're trying to get a patient off ECMO. But in the beginning, I think definitely there's also a risk that you don't have a good humidification, you don't have good secretion clearance, and also with constant high frequency, I think you can almost also be worried a bit about the impact it might have on the cannula position, and sometimes we have seen cannula movements as well. So I would be very careful, and I would advocate not to use high frequency in the early phases.
Great, thank you. Yes, I know I'm not a panelist, but I think APRV can be a great mode even for rest settings that I've used for our VB patients in the past. And then you can obviously increase to recruit. So I think that's a great strategy. So it sounds like everyone's in agreement about rest settings for our patient. How fast are you transitioning to these settings at your centers after cannulation?
Shall I go first?
Yes, that'd be great. Sorry, I should have called on someone.
I think I would say that I'd be totally guided by the clinical course. I mean, I would leave the patient on rest settings till I start seeing improvement. And what I mean by improvement is I start, seeing, hearing auscultation, on auscultation, some chest, good breath sounds, chest movement. When I start seeing air bronchograms on the chest X-ray, those are the signs to me that slowly things might be improving. And I may gently increase the ventilation to see whether there is any response. And as I said earlier, if I have them on pressure setting, then I would see an improvement in the tidal volumes generated. I would leave the FiO2 low, and I would leave the PEEP as it is, usually around 8 to 10. And I would say that when I'm relatively convinced that there is, good enough recruitment here to try a wean off ECMO, that's when I would give trials of modifying the ventilation and seeing what response I have. So I'd prefer to keep the child on rest settings till I have relative, confirmation that the lung has improved and is ready to be given a trial of.
Dr. Friedman? Are you putting these patients on their rest settings immediately after cannulation, or are you doing more gradual wean? Or
as soon as I remember to, obviously during ECMO cannulation, there's a lot of moving parts. And I think the biggest limitation to putting on rest settings is somebody thinking of it. So as soon as I do think of it, and our saturations are out of the 70s, I do transition over to rest settings very quickly and expect a significant decrease in my compliance and accept that. So yeah, I move to them very quickly as soon as we can. And then, I'm looking at the chat too, and I think Dr. Loftus brings up a good question about the CO2. She's asking how to reduce the CO2, and I use the circuit to control the CO2 and not the ventilator. And if a patient's had a prolonged increase in CO2, I do try to lower that more slowly over the course of 6 or 12 hours for the concern of neurological injury and the response of the cerebral vasculature to CO2. If it's been chronically elevated in a patient's ECPR patient or an ARDS patient who has a CO2 of 65, I don't really worry about it. If you're putting on an asthmatic that's had a CO2 of 120 for 2 days, that's a patient I'd be more concerned, or a BPD patient that's had a chronically elevated CO2. Those are patients I more worry about that.
Dr. Digeronimo?
Yeah, I basically agree. I think it depends, at least for me, a little bit on, how much support they're on. Are they going on more for hemodynamic or respiratory reasons? If they're on a ton of support, trying to back off on that sooner as opposed to later is helpful. I would say for most patients that go on VA, we pretty immediately, once the dust settles, transition over to our rest settings. I think for VV, it's a little different, given that, you're more dependent often on the patient contributing some ventilation, and you want to maintain lung perfusion. So I think, and I've certainly been burned, I think turning that down more or too quickly in a neonate, and then kind of having to go back up on settings some. So I think for VV, it should be a more gradual decrease, could be over even 12 to 24 hours, depending on, again, what the underlying lung disease is. And then for CO2, I think certainly in a neonate with brain autoregulation, again, if you have really high CO2s, a gradual advance in support and trying to do that more slowly as opposed to trying to correct that too quickly is important to think about.
Great, thank you so much. Moving on, Dr. Friedman, you had another ELSA registry review in 2021 that specifically evaluated rest ventilator settings in the pediatric VV ECMO population. What did that study tell us about the use of rest settings?
Yeah, so this paper was, the previous paper was, had a lot more granular data with less patients. The ELSA database collects vent settings at 24 hours and pre-ECMO, but for this study, we could only use ventilator settings at 24 hours. So it gives you a snapshot of the early management, but not much of the continual management. But it was enabled us to evaluate a lot larger group of patients, over 1,000 patients in this study of VV ECMO patients. And there was a lot more variability epidemiologically in the ventilator settings, especially the PIP and the FiO2. The PEEP was still relatively homogeneous, more variability, but still almost everybody was between 8 and 12 on the PEEP. What we're able to identify once again is that FiO2 seemed to be a driving factor for not a driving factor, I should say at all. It was associated with mortality, and this persisted with adjustments. So this FiO2 kept for me between these two papers rising to the top of my concerns, and I think PIP would be up there too, or driving pressure. But I think we're doing a pretty good job as keeping that driving pressure low in these patients, but doing less well getting that FiO2 reduced aggressively. Obviously, huge confounders here. We're probably turning up the FiO2 on the sicker patients, and there are probably confounders that I'm not accounting for. But that was the biggest takeaway for me from this paper.
Great, thank you. Kind of changing gears slightly, is there evidence for utilization of an open lung strategy on VV ECMO, and what settings might that constitute rather than being on quote rest settings? And is there an upper limit of ventilator support that you would utilize while on ECMO? We can start with Dr. Hoskote.
I would say that very, very rarely would I go for a total open lung strategy. I'd prefer to be on rest settings and then gradually open up. The only times I have tried to sort of use this sort of open lung or active recruitment is when we have a patient who's been on like say the second week of ECMO and we have not seen much improvement, then that's when I would sort of worry about it and try to use every recruitment strategy at that point. But to have open lung right from the beginning is slightly different. I wouldn't do that in the context of respiratory failure. Now, I need to qualify here further. Now, if we are putting children on ECMO for cardiac disease or cardiac failure, we are anticipating the lungs to be in relatively good condition. And we hope that here the lungs remain well enough that should the heart recover, then be ready to come off ECMO. So in that context, I would say the management of ventilatory strategies is different. And here, that's where I would like to keep the lung well inflated and ready. So, so that's what I would say about open lung. But if it is a pure respiratory failure, my aim is really to give this lung rest and go into lung protective strategies.
Great, thank you. Dr. Digeronimo?
Yeah, thanks. I think a neonatologist, and again, I think as I mentioned from the CHNC experience, we tend to target keeping the lung open for the most part. I think people, and neonatal runs tend to be short for respiratory failure outside of CDH. So the goal of trying not to let the lung collapse is, I think, what a lot of people target. There were a couple studies in the literature that were done. Marty Kessler back in the early 90s looked at a higher PEEP versus lower PEEP strategy. And they used fairly high PEEPs of like 12 to 14 in that study. And in the high PEEP group and the low PEEP group was like 3 to 5 or something like that. And they showed by keeping the lung open that babies had significantly less time on ECMO, better lung compliance, and less complications. And then there was a more recent study by Pedi and the kind of the Mars group that looked at the ELSO database. And again, in that population found that using a higher PEEP strategy, keeping the lung more open, those patients also had less time on ECMO with similar survival. So again, I think it depends a little bit on the patient. And again, I think it depends on VV versus VA and the anticipated length of the run of ECMO. But, for a shorter anticipated neonatal run, I think trying to keep the lung reasonably inflated is a good strategy.
Great, thanks. Dr. Friedman?
For me, it's one of those, it depends questions. I think, I would never use excessive driving pressures to open up the lungs. But for me, it's always a kind of risk-benefit analysis. If I think I can keep the lungs open by using a PEEP of 12, slightly higher than our standard of 10, I might do it. But if I think it's going to take 18 or 20 or an oscillator with a MAP of 30, well, that doesn't seem like a prudent decision. And the second thing is obviously, is going to be the stage of illness that you're in, and what your goals are. You just get on ECMO, my lungs are going to collapse, and that's fine. You get 3 weeks in and you're having major complications, well, then you might need to be more aggressive about getting those lungs open and keeping them open.
Great, thank you. Dr. Zivik, you had some questions from the chat.
Yeah, I think the first is somebody was asking what is your management strategy for titrating FiO2 and maybe people on, while patients are on ECMO, if their SATs are low on VV, 60 to 75%, potentially from high cardiac output. Do you try to use the vent or try to get to rest settings and focus on oxygen delivery as opposed to SATs was sort of one of the big questions. I don't know, Dr. Hoskote, if you want to start.
My aim would be here in this situation is to try and use the ECMO circuit to deliver the oxygen, to focus on the oxygen delivery. So I prefer not to use the ventilator to help with low oxygen saturations. I prefer to use the ECMO circuit and optimize the flows, optimize oxygen delivery. Again, also I'm looking at what the systemic perfusion is like with the saturations and what impact it has on the systemic oxygen delivery. And I think I would be more focused on using the ECMO circuit.
What about if there's severe pulmonary hypertension?
Now, in terms of titrating inhaled nitric oxide, is that from the chat or just
both FiO2 from the vent and inhaled nitric oxide?
So I normally would not use inhaled nitric oxide on ECMO in the initial phases of going on ECMO. No, my strategy would be to use inhaled nitric oxide when I have seen lung recruitment and I've given an attempt to come off ECMO, and yet I'm seeing significant pulmonary hypertension, and then I might use inhaled nitric oxide to bridge me over to coming off ECMO. But to use that for this is I'm talking in terms of standard respiratory illnesses that cause severe respiratory failure and lead to go on to lead to the need for ECMO. Now, it might be slightly different for situations where congenital diaphragmatic hernia and you have severe pulmonary hypertension, and then you're trying to come off ECMO when there is enough recruitment and yet there is severe pulmonary hypertension. Then yes, inhaled nitric oxide might start a little earlier before coming off ECMO or giving the trial of wean of ECMO flows. But using oxygen, I prefer not to. And if I have to use oxygen to improve from the ventilator to improve the saturations or oxygen delivery, then I need to look at the circuit and find out the problem there is. Why am I not able to achieve with ECMO flows?
Great, thank you. Dr. Digeronimo?
Yeah, I think similarly, neonatologists don't like oxygen. And I think giving oxygen to the lung through the ventilator is, it's potentially toxic to the lung. So, getting the FiO2 down is one of the, I think more of the universal principles of lung rest. So I think outside of maybe a VV baby that, you don't quite get enough support from your circuit and you're needing to, again, use the patient's lung to help with your ventilation and oxygenation, that would be really the only scenario where maybe, they would be on a little more oxygen versus trying to be on room air. I think, we don't really know that, by providing oxygen or inhaled nitric oxide that, that's going to reduce your pulmonary hypertension any more quickly or improve outcomes or, time on ECMO. So I think certainly for VA ECMO, and I think as some people were saying in the chat, if your lungs collapse, it doesn't make a lot of sense. You're not going to get any benefit from the nitric. So I think turning that on more as you recruit the lung, if you de-recruited the lung, would make more sense. Or as you get closer to coming off, that's where adding nitric back in or using a little more oxygen for as you approach kind of trialing off makes more sense.
Great, thanks. Dr. Friedman, you want to speak to this one?
Yeah, you don't have to tell me not to use FiO2. I think Dr. Hoskote hit it on the nail on the head. It's the circuit. Figure out a way to do it with the circuit. You know, we're now, I think we're a little bit spoiled now with the bicaval cannula and the saturations we're expecting. Those of us that practiced prior to those are used to seeing very low sats on VV ECMO, dual lumen cannula, high recirculation. If I can get my sat above 75, I'm happy with that. So the biggest thing for me is setting the expectations with the bedside team that a sat of 81 is fine, and please do not go up on the ventilator FiO2. And then the only thing I'd speak to the nitric is, you know, the prolonged VV, there's the risk of RV failure. So if you're having issues with RV failure, then, you know, nitric might be indicated, but you're also probably more likely to try something that's more of a long-term pulmonary hypertensive intervention that's not, you know, inhaled nitric, whether it be sildenafil or treprostinil or something else that's not nitric. But that's the one indication I've used it for on VV ECMO.
Great, thanks. All right, we're going to move along with a progression of our case. The patient's now been on the rest settings that we discussed in VV ECMO for a week with no improvement of his X-ray. The team begins to discuss the utility of various mechanisms of airway clearance. So what types of airway clearance do you all utilize on ECMO, be that, you know, IPV, bag lavage suction, chest PT, etc.? We can start with Dr. Digeronimo.
Yeah, so in this scenario, again, I think, you know, if you're using more of a lung open strategy, I think, you know, keeping neonates on PEEPs of, you know, 8 to 10 or on the higher end, those, you know, it's less likely you're going to need much to recruit the lung, especially, again, I think in shorter runs that don't involve air leak and outside of CDH. So I would say having to use lung recruitment strategies in the NICU for ECMO is less common. But I think first to get the lung recruited, if it is de-recruited, you know, using the ventilator would be the primary tool. As mentioned previously, going up on the PEEP or other settings, or this might be a scenario where you convert to high frequency to try to open up the lung. But if those things are not working, then I think all of those things you mentioned potentially have a role. I think, you know, bag suctioning can be helpful, again, depending what your rest settings are. I don't know if we're going to get to bronchoscopy more specifically, but, you know, we certainly do that on occasion in the NICU. And it, you know, especially in a patient who had a pulmonary hemorrhage, or you're worried that there's a lot of clot or, you know, other obstruction that, you know, regardless of how much you turn up the ventilator, you're not going to open up the lung. I think we would tend to bronch that patient sooner as opposed to later to remove the obstruction. Yeah, I think that's my general thoughts on that.
Great, thanks. Dr. Hoskote?
I'm just thinking here, if it's 1 week and no improvement, I would just persevere. I would just continue. I wouldn't worry. I would give more time. What I'm trying to see here, that the ECMO is working well, that the cannula position is fine, the patient is stable, there's no other end organ dysfunction, and the patient is well supported with nutrition, and that's what I would just wait. One thing I want to highlight, and this hasn't been said so far yet, I think it's very important that as soon as you go on ECMO is to initiate good respiratory physiotherapy. And we have, team of excellent physiotherapists on whom we rely a lot, who start working on the patients right from the beginning, and they have a series of maneuvers that they do. Sometimes it might be just directed saline lavages, sometimes postural drainage. So various strategies that are there, and we have a system where we have ready, steady, go. That is, we use it every day on our morning ward rounds, where we look to say, whether the patient is ready, steady, or go in terms of, giving more rehabilitation and physiotherapy. So I would say that that's where my focus would be. And the role of bronchoscopy comes in when we feel that maybe there is thick secretions and there's absolutely no aeration seen. But my first strategy is still to have good respiratory physiotherapy whilst on ECMO.
Great, thank you. Dr. Friedman, do you have anything to add to that?
Yeah, we have a slightly different approach where we were fairly aggressive with bronchoscopies and less so with the non-invasive chest physiotherapy and treatment therapies. We typically will, if lungs are collapsed, we'll typically bronch, and I'd say mostly around day 5 to 7 if you're not seeing any improvement. Not that you fully expect every patient to be better by then, but there's plenty of patients we've gone in and found lots of thick secretions, casts, things like that require multiple bronchoscopies. So if secretions are a big problem, we tend to need multiple bronchoscopies. We like to get that started within that first week. I think it's interesting that which approach is would be more efficacious. I think would be an interesting question between the way we do things and the way Dr. Hoskote does things. It's showing the differences in practice.
Yeah, for sure. And when you guys are going to bronchoscopy, are these flexible bronchs, rigid bronchs, and who's doing that? Is that a general surgeon, an otolaryngologist, the intensivist, or pulmonologist?
Our pulmonologist. We do flexible bronchoscopies by our pulmonologists. And we often sometimes use this particular subset that are very comfortable with kind of these potentially higher risk bronchoscopies.
How about you, Dr. Hoskote?
In ours, it would be the pulmonologists who do bronchoscopy. We do have some few members of our ICU team who can also do bronchoscopies, but by and large, it is pulmonologists. Now, if there is an airway issue, then our ENT surgeons would help with bronchoscopy as well. So, and that's would be usually it's fiber uptake in the first instance.
Great, thank you, Dr. Digeronimo.
Sorry, muted. The problem I think we run into in the smaller patients is trying to do a flex bronch through the ET tube. It's really hard to clear secretions. So I don't think we've had a lot of success with that. So when we have plugging or clot, we tend to use ENT and go to the OR. You could do it at the bedside, but really removing the tube and having them do a more kind of open airway clean out. I think we've had more success with that. So that's what we tend to do.
Great, thank you. Dr. Friedman, last year you published a study evaluating the practice of bronchoscopy in pediatric patients with ARDS on VV ECMO. What did that study tell us about the potential benefits of bronchoscopy, and what about some potential complications that may arise?
The study was done in concert with the first one I spoke about. Dr. Rosner led this, but we utilized the data collection together. So it's the same 10 centers and patients that for the previous study, we looked at almost 300 bronchoscopies in about 130 of the 204 patients. We found as far as efficacy, we saw increases in compliance and increase in tidal volumes after bronchoscopy, which was somewhat expected, but good to see that the bronchoscopies may be helping our patients. As far as the complications of bronchoscopy, we found them to be extremely few. Only four complications were seen after the 271 bronchoscopies, so an incidence of less than 2%. The main complications being pneumothorax and pulmonary hemorrhage. So the complications were quite low, which was good to see. As far as the effects on outcomes, it was really hard to tell. It was a little bit of a mixed bag. You could see flexible bronchoscopy was associated with longer ICU stay and fewer ECMO and vent-free days. That may be selection in that patients that are on ECMO longer are getting bronchoscopies as opposed to be causative. Because when we looked at early versus late bronchoscopy, patients who had early bronchoscopy had better outcomes than late bronchoscopy. So I think it's hard to say bronchoscopy improves outcomes because of the selection bias, but we definitely saw low complications and improvements in lung compliance.
Great, thank you so much. All right, our case, or at least do you have any sorry, Dr. Zivik, do you have any chat questions you want to say right now, or are you going to keep going?
I think there's just a little bit of discussion about the sort of RV, some atelectasis causing RV failure, pulmonary hypertension going on in the chat. And so I think we can keep going.
Okay. So our case is progressing. We're now on ECMO day number 15. The rotating emergency medicine resident asks about potentially lightening the sedation and extubating our child, noting that they'd seen that in the adult ICU. This begins a discussion about the potential benefits and risks of extubation for patients supported on ECMO. So do you all extubate patients like this child who's supported on ECMO in your institutions? And things we could talk about surrounding that would be some proposed benefits of that, risks, patient self-inflicted lung injury, and ways to mitigate the tachypnea that can be seen on VV ECMO. And do you have any specific criteria that your child or children need to meet before you want to extubate on VV ECMO? And I'm happy to repeat any of those if y'all need to. We'll start with Dr. Digeronimo.
I have extubated several babies on ECMO. I don't think it's a widely done practice. Again, we've talked about this within CHNC sites. There are a handful of centers that I think are more willing to do it. There's not much in the literature about any benefit of doing that, other than anecdotal kind of case reports. There was a case series that was published a few years ago, again from the Mars group, who probably has the most experience with doing this. But I think it potentially will make sense for for an air leak patient. I think is where people have used it, where again you're turning down the ventilator so low anyway, and you want to get rid of refractory air leak, letting the patient spontaneously breathe has worked the one or two times I've done that. It is true also that the babies particularly require significantly less sedation. You could potentially even feed them. It does have some nice benefits, but again, whether that I think makes a difference in outcome ultimately is there's just not data to support that. And then all of them are going to get reintubated when you to get off ECMO. I don't know anybody who would decannulate with an extubated patient, so you're going to end up reintubating them. So it also depends, again, a short run, it probably doesn't make a lot of sense other than for air leak to pull the tube. But maybe on a longer run patient, there may be some benefit. But I think more to learn about that.
Okay, Dr. Friedman.
So yeah, we've done it a few times. I'm not a huge personal fan. This is just I'm speaking to opinion, not based on data. And I think that's largely due to the issue you brought up of the patient-inflicted lung injury due to severe negative pressures. I've witnessed that, and I think patients that have that, their lung, anecdotally, their lung injury takes longer to resolve, and you may have been better off staying on positive pressure ventilation. So I think being really wary of that, those patients with those extreme negative pressure ventilation when they're with whited out lungs, I don't know that extubating them is the best thing for them. And the second thing, and if you're doing it for prolonged VV ECMO course, make sure your ECMO course is going to be long enough to realize the benefit. I mean, I think that one of the big benefits is getting off sedation, limiting the brain's exposure to sedation, improving your ability to rehab the patient. And it takes time to get there in the patients that we've either extubated or done tracheostomy, which is our preferred practice on most patients. It takes a good 2 to 4 weeks to go from decision to extubate or tracheostomy to really realizing that benefit we all like to talk about of, we're going to walk this patient on ECMO. It sounds great and everybody loves seeing pictures of that, but that doesn't happen in one day. That takes weeks of effort and concerted effort to get a patient from a sedated, intubated position to kind of a more mobile, awake ECMO status.
Great, thank you. Dr. Hoskote?
I think personally, I love the concept of awake ECMO and the ability to have good airway clearance, with better cough and rehabilitation. But practically, I must say that my experience with awake ECMO has not been good, and it's very limited. We do not go for it unless we're reasonably comfortable that the patients will be able to manage. And what I have found is that in the few that we tried, that the children can get quite scared sometimes. They're not able to handle the secretions really well. I remember an instance where a child started coughing and then got epistaxis, and then we were very worried about the bleeding at the back and the nose and the throat, and we reintubated. So I would say that I like the concept, but practically, I don't think I would go for doing that unless it's a very highly select group of patients. There may be older patients who you can talk to and they can understand you, and I think in those very highly select group, maybe, but not in this child. I wouldn't be thinking of, awake ECMO.
Thank you. Yeah, I was curious if, and y'all have spoken to this a bit, like if the child's neurologic status or age played into your decision making to extubate the child. Obviously, Dr. Digeronimo's patients are always going to be young, but does that ever come into your mental calculations to whether to extubate the child or not? I'll ask Dr. Friedman since Dr. Hoskote already answered.
Yeah, I mean, I think it goes back to kind of, can I get them to realize the benefits of extubation and the benefits of early benefit you get right away, the other benefits of awake ECMO, take work, a whole team of your RTs, your RNs, your ECMO team, your rehab team, your ICU team, and that takes time to realize. And if they're not neurologically appropriate, whether that be to age, pre-existing conditions, or sedation needs, then it's generally not worth extubating if you can't realize those benefits.
Sure. And sorry, go ahead, please.
Matt, sorry, I just wanted to touch on the chat. There's quite a few people sharing their experiences with extubating patients and weaning to decannulation on high flow, low flow, extubating to allow for rehab for lung transplant, but then converting some of them to central cannulation for better control of the cannulas, which is an interesting strategy. And somebody commented they felt like mucus clearance could be better on awake extubated patients. One question is, does anybody, and this is really more for the littlest ones that we take care of, any experience extubating with an RA cannula in place?
Not me.
No.
No, also.
I should caveat, I don't do lung transplants at my center, so I think that the lung transplant population, I think, is more similar to the adult population than a lot of the other pediatric groups as far as awake ECMO.
And to Dr. Friedman's earlier comment, and a question I have is, do you ever consider, instead of extubating, doing a tracheostomy and then weaning the ventilatory support to off with this? You still have your stable airway if you want to put the patient back on the ventilator for decannulation, what have you, or airway clearance.
Well, easy for a neonatologist. We would rarely, if ever, trick a patient. Yeah.
We're moving in that direction, more tracheostomies in these patients. Not most of them, but a definite percentage of them. We probably around week 2 to 3, if we're not seeing improvements, we start having those conversations. Not necessarily doing it, but having those conversations. And I'd say by week 4, if our patients are not improved, I'm personally advocating for tracheostomy if I'm not seeing benefit and I think we can do the procedure safely, which we can in most patients.
Dr. Hoskote?
Yeah, similar to what Matthew just said. We wouldn't be going for tracheostomy any earlier than 4 weeks. We have done very few, so by and large, we have been fortunate enough to be able to get our patients off ECMO by then. But in the odd situation where we've not been able to, we would consider tracheostomy. But by and large, our aim is to try and hopefully have enough lung recruitment to come off ECMO by then.
Great, thank you guys so much. I think in the interest of time here, we're running close to the hour, it looks like. Dr. Zivik, any other comments or questions from the chat from the participants?
I don't think we have any other comments. People were sharing their experiences with extubating with a RA cannula in place. And I think this actually, somebody just put a question in the chat that I think would wrap things up nicely, which is really the question of what, and it may be that they were talking about 4 weeks of doing a tracheostomy, 4 weeks is too late. But I think really the big question is on everybody's mind is, how long is too long to keep somebody on? If you're, what do you consider when you're starting to think about if the patient's not getting better, what do you do? How long do you wait? And then if they are getting better, how do you start to escalate your support and recruit your lungs? So Dr. Friedman, do you want to start with that?
Yeah, so our longest VV ECMO run, I think, was about 6 months. That patient got a trach, but then was decannulated about 6 months after their ECMO stay, and now is a normal kid walking around. So at least 6 months, is reasonable. I think a lot of people have heard about the Johns Hopkins patient that was, I think, 13 months, was a burn patient that they had an ECMO for 13 months, and I believe is now decannulated from their trach. So, as we push the limits more, we're finding the lung has abilities to regenerate that we didn't realize. Our general practice has been around the 3-month mark that we would consult a lung transplant center for a second opinion, not necessarily saying we want to move them there. For us, St. Louis is the closest one. For kids or potential, if they're older teenagers, we look at Loyola in Chicago. So we would talk with one of those places around the 3-month mark just to get an opinion, see where they're at and what their thoughts are. But the 3 months isn't a definitive cutoff. It's just kind of a good time for us to talk to somebody with more experience in this.
Anybody else?
Yeah, I would just add, for a patient similar to our scenario, for a neonate, it's pretty unusual not to be better by 2 weeks outside of CDH. So I think if you had a patient in this scenario where you don't have a good underlying etiology, nowadays we would, if we're, 3 weeks into it and the patient's not getting better, we would consider a lung biopsy and or genetic testing. We may also do genetic testing much sooner, again, if the patient doesn't have a lot of lung disease, but has bad pulmonary hypertension and hypoxic respiratory failure without a good etiology. So I think thinking about those other, trying to come up with an etiology of why you're still on ECMO is important. And really outside of, standard respiratory failure, the CDH patients are the ones that tend to have longer runs. And I think there's good support in the literature that once you get out, past 4 to 5 weeks, your ability to get better, really has diminishing returns on ECMO. So I think if we're that far out, especially for a CDH patient, we would be looking at trying to optimize what we could and coming off.
Yeah, I think my experience would be something similar to what Bob just said. I think if you're not able to get a patient off ECMO or there's no lung recruitment at all, then you need to worry what's going on. What is the underlying disease here? What's the problem? Is there something that's more than what we can, reasonably achieve by just keeping on ECMO? We haven't done lung transplant, though we are a lung transplant center. We have not bridged patients to lung transplant. The wait to get an organ is exceedingly high. It's much more than one can, I expect the waiting time on ECMO, it wouldn't permit safe waiting on ECMO. The wait time for an organ is just too long. We would sort of, if there is a situation where there's absolutely no lung recruitment, there's nothing at all, then we would again go back to what the primary etiology is and discuss whether lung transplant is a reasonable option, and if not, then it would be redirection if we're going to such long waiting time.
Well, great. Thank you guys so much. This has been an amazing discussion. We wish to thank Dr. Friedman and Digeronimo and Dr. Hoskote for their time and their expertise, and to Dr. Zivik for organizing this with us. I'm going to turn it back over to her.
Yeah, thank you guys so much for joining. We had a great turnout. If you are so inclined, we'd love for you to scan the QR code and give us some feedback. We are always open to hearing about what you guys want to hear and learn about with these webinars. We try to do, this is our 4th this year. We try to do them at least quarterly, and so we may be able to squeeze another one in either later this year or early next year. And again, so that the QR code is there if you want to screenshot that. And then really just remember, Pedi ECMO meeting is next week, and there will be some limited virtual options if you are not able to make it out to ELSO in Seattle. And so you can join from anywhere if you're free at that time. And there is the registration link that I will try to throw in the chat here. So thank you guys so much for joining, and thank you to all of our panelists. I think this was a great session.
Thank you.
Thanks, guys.
Great.